Welcome to this educational video on how to help your surgical patient quit smoking in the perioperative period. As a major life event, surgery can serve as a catalyst for patients to quit smoking. Patients who have a major surgery are 50% more likely to have a successful quit attempt. With around 10 million smokers undergoing major surgery every year, this presents a huge opportunity for surgeons to intervene. Cardiovascular complications include myocardial ischemia and infractions through several mechanisms that disrupts oxygen demand and supply to the heart. Smoking constituents creates a hypercoagulable state by increasing platelet aggregation. Smoking constituents can increase sympathetic activity, thereby increasing HR, heart rate, and MAP, mean arterial pressure. It reduces oxygen delivery to the heart through coronary vasoconstriction and by carbon monoxide hindering hemoglobin's ability to transport oxygen. It takes only hours for the beneficial CV effects to be seen due to the short half-life of nicotine. Pulmonary surgical complications. The most important pulmonary complication of smoking is pneumonia. Contributing factors include impaired ciliary function and enhanced mucus production. Tobacco's toxins can also impair the lungs' immune system by decreasing pro-inflammatory cytokines and macrophages. Impaired healing of bones in surgical wound. Studies confirm that smoking is a risk factor for wound dehiscence and infection. Nicotine and CO produce peripheral vasoconstriction and bind to hemoglobin, respectively, both of which are deterrent to tissue oxygenation, an important determinant of wound healing. Smoking constituents can also directly impair function of cells such as fibroblasts and immune cells involved in the process of tissue healing. Generally, the rate of wound-related complications in former smokers is like those who have never smoked. Ask, advice, refer. A framework approach designed for physicians to help their patients quit is called the 2A's and R model. It involves 1. Asking about smoking behavior, 2. Advising patients to quit, and 3. Referring them. In this video, we will teach you how each element of this model can be tailored for surgical teams to help your patient quit. Ask. Inquire about tobacco use even if you already know the answer. This can be done simply by asking, "Mr. Jones, I have another thing I would like to discuss with you. Do you use any tobacco products?" Your advice should be strong and personalized to have an impact on patients' smoking habits. Put an emphasis on the benefits of abstinence on mitigating perioperative complications and the long-term benefits of quitting. Use what you learned about smoking-related complications in surgical patients to deliver such strong and personalized advice. Have you ever tried to quit? Yeah, with no success. I recommend all my patients stop smoking before surgery and for at least 1 week after surgery. Just like you shouldn't eat on the day of your surgery, you shouldn't smoke on that day either. The longer period you can stay off smoking before and after your procedure, the better chance of reducing complications. Starting now, if possible, because this helps you have the best possible result for your surgery. What do you think about that? Refer. Another way to assist your patient is by connecting them to 1-800-QUIT-NOW-QUIT line. This will connect patients to state-sponsored tobacco quit coaches who will work with patients through phone, online, or in person. These services are completely free of charge, and nicotine replacements are also provided at no cost. Make sure to emphasize that these resources work. Quitting is difficult, but you are not alone, and you don't have to do this on your own. Many smokers have found the telephone quit line very helpful. Some states also provide in-person counseling if you prefer, all of which are free of charge. Here's their number, 1-800-QUIT-NOW. I recommend that you give them a try. They can be very effective.